So good morning. So we we're gonna continue with pharmacology, but we're gonna start from the beginning today. So when we say pharmacology, we know it have to do with medications, but it's a little bit more than that. What we do, we talk about pharmacodynamics. We talk about pharmacokinetics. And pharmacodynamics and pharmacokinetics, we're going to go a little bit more in detail, but it's basically, um, you know, how the drug affect the body. So what effect that the drugs have on the body, and then what effect that the body has on the drug. So you have to look at it. The medication is going to affect the person who is taking uh, the medicine. So the medicine is going to affect the person taking the medicine. And then the person who's taking the medicine going to modify the drug somewhat. So, the individual is going to change the medication then. Okay? The medication may be converted from, say, a prodrug that is an inactive medicine to a now active medicine. So the person is also going to have some effect on the drug or the medication. In particular, we're going to look at different class of medications. We're going to look at the angiotensin converting enzyme inhibitor, ACE inhibitor. We're going to look at HARBs, which is angiotensin 2 receptor antagonists. We're going to look at beta blockers, calcium channel blockers. We're going to look at digoxin, nitroglycerin. Uh, in our first session, we look at antiarrhythmics, very important. We'll also look at statins. We'll look at the cancer drugs, including doxorubicin. We talk about dobutamine, atropine, persantin, and adenosine. All right. So going back to pharmacology, when we talk about pharmacology, it's basically the interaction between drugs and a living organism. Okay? So it's just that interaction. And as we pointed out before, the drug is going to have certain effects on the organism, and the organism is in turn is going to have certain effects on the drugs. So, nothing too complicated. It's just the interaction between the two components, the drug and the organism. So, in specific, when we talk about pharmacodynamics is the effect that the drugs is going to have on the living organism. So we take medication because it's going to produce certain effects in us. So that is called pharmacodynamics, the effect that the drugs have on the organism. And then pharmacokinetics now is the effects that the living organism is going to have on the drugs. So when we take a drug, it has to be absorbed. So if we take the drug orally, or if we inject it into the muscle or the bloodstream, it has to be absorbed and then travel through the bloodstream to produce its effect. So it has to be absorbed. Okay, so the living organism have to absorb the drug. Okay, then when the drug is absorbed, say you inject it, then the drug has to distribute. It has to spread throughout whatever area to produce its effect. So it has to be absorbed, it has to be distributed, okay? And when we talk about distributed, that means mainly the bloodstream. The bloodstream is going to take the medication to all over the body. And then metabolism, when we say metabolism, is the breakdown of the drug. So when we take a drug, first it's absorbed, okay? If we take it, say, orally, then it has to be absorbed either through the mouth, it can be absorbed in the mouth, or it can be absorbed in the gastrointestinal tract into the bloodstream. Then the bloodstream will distribute the medication throughout the body. And then when the drug, some drugs are what we call prodrugs. That is, they're not active, they're not going to do anything until they're converted to another compound. And the body have enzymes and the ability to convert these drugs into their active form. After the drug produces its effect, then the body will cause what we call metabolism, breakdown of the drug into an inactive form. And that can occur in the liver, the kidney, usually liver and the kidney, but it can occur elsewhere. So that is what we call metabolism, the change of the drug from one form to the next. As I say, it could be a prodrug, and you convert they convert the medication to the active form, or you can break down the medication to an inactive compound. So that's called metabolism. So once you finish with the drug, then you eliminate the drug from the body, and that's excretion. So you can excrete the drug, usually, in the kidneys or the gastrointestinal tract or the skin. You can excrete drugs multiple ways, but usually the GI tract or the kidneys. All right, and so the first medication that we're going to look at is called the ACE inhibitor, and then we're going to look at the HARB, angiotensin receptor blocker. But first, you have to understand a little bit about what we call the renin angiotensin aldosterone system. This is a very important system because we maintain our blood pressure, or we have a blood pressure because of this system. And when we talk about this, it's also called the RAS system, RAAS, the RAS system, the renin angiotensin aldosterone system. Okay, so renin, first of all, angiotensinogen. So angiotensinogen is it's a protein. It's not an active protein. Okay, it is produced in the liver. So angiotensinogen is produced in the liver. Now this inactive protein is converted to an active protein by what we call renin, and renin is produced by the kidneys. So your angiotensinogen produced from the liver, or produced by the liver, is converted into angiotensin 1 by the action of renin from the kidneys. Okay, so renin is produced by the kidneys. Then this angiotensin 1 is converted to angiotensin 2 by an enzyme we call ACE. So this is angiotensin converting enzyme. So, a lot of these things are sort of self-explanatory. So angiotensin converting enzyme converts angiotensin 1 into angiotensin 2. Now, angiotensin 2 does a lot of stuff, okay? One of the main things that angiotensin 2 does is to constrict what we call vasoconstriction. It makes the blood vessel smaller. That's the lumen, the diameter. So it constricts the blood vessel and it increases blood pressure. So one of the main thinking is that this angiotensin 2 is one of the main culprits for producing high blood pressure, because once it's produced, it's going to cause vasoconstriction, constrict the blood vessel, and send the pressure up. It does a lot of other things in that it just one sec. So, there angiotensin 2 does other things. It acts in the pituitary gland and it causes the secretion of ADH and stuff like that. It also acts on the kidneys, okay, and it acts on the adrenal cortex and brings about the production of aldosterone. So aldosterone is another, it's a hormone that is produced, and it does good things, but it also can do a lot of bad things too. Aldosterone. It acts on the kidney again to cause tubular reabsorption of potassium. Okay, so it causes a reabsorption of potassium. Um, Sorry, it causes tubular reabsorption of sodium and chloride, and then potassium excretion. So it actually, angiotensin 2 actually cause the what we call sodium and water retention, and it eliminate potassium from the body. All right. Okay. So these are some of the things that angiotensin 2 does. So you can see immediately, if you have too much angiotensin 2 in the body, so a lot of bad things that can occur. Increase the blood pressure, you get sodium and water retention, you lose your potassium, okay, and you're going to secrete aldosterone. Too much aldosterone, especially if the patient have a bad heart, it can affect the heart. All right. So again, this is the RAS system, renin-angiotensin aldosterone system. The angiotensinogen is produced by the liver. It is converted to angiotensin 1 via renin, which is produced in the kidneys. This angiotensin 1 is now converted to angiotensin 2 by the ACE. It's an enzyme, angiotensin converting enzyme. Okay? And this enzyme, it's produced in the lungs and the renal and the kidneys as well. Okay, so the angiotensin 1 is converted into angiotensin 2, and your angiotensin 2 cause vasoconstriction. So it helps to maintain blood pressure, but you can also get high blood pressure from it. Okay, it acts on the kidneys to increase your production of aldosterone. Okay, and your aldosterone and angiotensin 2 can cause salt and water retention. Salt is sodium, okay? Salt and water retention, and the elimination or excretion of potassium. All right. So this is the RAS system. Now, when we talk about, so we have seen a lot of bad things that angiotensin 2 does. So if we can block angiotensin 2 receptor, or what we call angiotensin 2 receptor antagonists, or ACE inhibitors. Sorry, this is the harm. So, okay, let me try not to confuse you. So when you produce your angiotensin 2, the angiotensin 2, which is a hormone, is gonna act at certain receptors. It's gonna attach to certain receptors, say in the kidneys, on the blood vessels, wherever it's going to produce its effect, and then produce the effects. Okay, so once it's attached to these receptors, then it causes certain change in the cell to produce its effect. So if you have something that can block these angiotensin 2 from attaching to the receptors, then you can reduce the effects. And that's what we call the angiotensin receptor blockers, or angiotensin 2 receptor antagonists. Okay? So you're just blocking the angiotensin 2 from attaching to receptors. And we have medication that does that. So what is the mechanism of action? How does these medicine work? So again, they block the angiotensin 2 from attaching to the receptors. Okay? And remember, we know that angiotensin 2 does a lot of bad things. So if you block angiotensin 2 from attaching to the receptors, you can get vasodilatation. The blood vessel dilates as opposed to constrict. You can reduce what we call vasopressin, and you can reduce the production and secretion of aldosterone. Again, as we said, aldosterone, which is a hormone, is bad in patients who have, say, heart failure with reduced ejection fraction. Patients with depress LV systolic function, aldosterone will cause further weakening of the heart muscle. So if you can block the attachment of your angiotensin 2 to the receptors, you can reduce the effects of aldosterone, or well, you can reduce the production of aldosterone. Okay, so if you have someone who have high blood pressure and you block the 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 angiotensin 2 from attaching to the receptor, you can get vasodilatation. So we can use it to treat high blood pressure. And again, if you have patients who have heart failure with reduced ejection fraction, and we said too much aldosterone can further weaken the heart muscle and cause the patient to be congested. So if we block angiotensin 2 from attaching to the receptors, we can reduce the production of aldosterone. So what we call HARB, ARB, angiotensin receptor blockers, we can use those type of medication to treat hypertension and heart failure. So we use it for the treatment of hypertension. It's also beneficial. It protects the kidneys in diabetic from deterioration. So we also use it for diabetic nephropathy, okay, to prevent diabetic patients from having kidney problems. And then heart failure, especially patients who have heart failure with reduced ejection fraction. As we pointed out before, one of the things that angiotensin 2 does is to increase the production of aldosterone. And aldosterone cannot further weaken the heart muscle. So we use it for that. So that's the or so-called HARB. Okay. All right. So we're gonna look at ACE inhibitors. All right. No, we're still on ARB. So what are some of the adverse effects? What are some of the bad effects of the HARBs? Okay. So remember now, HARBs, just these are a medication that prevents the attachment of your angiotensin 2 to the receptors. They have to attach to the receptors to produce their effects. So the angiotensin receptor blocker prevents the attachment of your angiotensin 2 to the receptors. So some of the adverse effects are dizziness, okay, headache, hyperkalemia. So remember, one of the things that your angiotensin 2 does, it causes the excretion of potassium. So you're going to lose potassium. So if you block the effect of angiotensin 2, it can increase the amount of potassium in the body. And that's what we call hyperkalemia. Okay? Kalemia is potassium. So hyper is increase. So you increase the amount of potassium in the body when you give these type of medicines. Okay, you can also get orthostatic hypotension. That is when you stand up, the blood pressure falls. Okay, and just like any other medicine, you can get skin rash, dyspepsia, which is discomfort in the stomach, myalgia. You can get muscle aches, insomnia, inability to sleep, and it can damage the kidneys as well. It can also cause something what we call angioedema. That is, it's an allergic type reaction where you get swelling in the mouth and the throat, and this can be life threatening. So you have to look out for this then. Okay. So these are some of the HARBs or angiotensin 2 receptor blockers that we have. Okay. Angiotensin 2 receptor blockers are HARBs. So losartan, the other name, the trade name is Cosar, okay, losartan. Candesartan, that trade name is Atacand. Valsartan, trade name is Davan. And then irbesartan, Avapro. Telmisartan, Mycardis. eprosartan, Tevitan. We don't use this too much anymore. Olmesartan, which is Benicar, and we don't really use this much. All right, so those are some of the more common ARBs. Okay. All right. So now we move on to our ACE inhibitors. If you remember when we look at the RAS system, again, angiotensinogen produced in the liver is converted to angiotensin 1 via renin, which is produced in the kidneys. Then your angiotensin 1 is converted to angiotensin 2 via ACE, angiotensin converting enzyme. And then the angiotensin 2 is going to do all these things. So if you block your angiotensin converting enzyme, so this is ACE, we call these group of medicines ACE inhibitors, angiotensin converting enzyme inhibitor. So they block the conversion of angiotensin 1 to angiotensin 2. So you're not going to have the effects of angiotensin 2 because you block the conversion of angiotensin 1 to angiotensin 2. So what is the mechanism of action of these medicines? So as we pointed out before, the medicines are going to inhibit the conversion of angiotensin 1 to angiotensin 2 by blocking the enzyme. So that's why they're called ACE inhibitors, angiotensin converting enzyme inhibitors. Okay, so remember, angiotensin 2 causes vasoconstriction, increased production of aldosterone, all those things. So if you block that effect, then what you're going to have is vasodilatation. The blood vessel is going to dilate. You're going to decrease your production of aldosterone, and you get an increase in what we call bradykinin and reduced vasopressin. So we use ACE inhibitors to treat hypertension, just like our ARBs. We use it in diabetics with kidney problems to prevent diabetic nephropathy. Okay, that is use it to reduce kidney problems in these patients. Okay, and also congestive heart failure. So patients with heart failure with reduced ejection fraction. As we pointed out before, patients with heart failure with reduced ejection fraction, aldosterone is bad for these patients because it further weakens the heart muscle. And again, angiotensin 2 increase the production of aldosterone. So when we inhibit our angiotensin 2, we reduce aldosterone production, and it's beneficial for these patients with heart failure with reduced ejection fraction. So that is our ACE inhibitors, okay? And so these are some of the side effects, or what we call adverse effects then. The adverse effects of ACE inhibitors, hypotension, you can get orthostatic hypotension. That is when the patient stands up, the pressure falls quite a bit. Very important, cough. So, and we will stop these medications because the patient may have a very troublesome cough. So it's fairly common for these patients who are taking ACE inhibitors to develop a cough. And again, hyperkalemia, remember we said that angiotensin 2 brings about the excretion of potassium. So if you're blocking angiotensin 2, you can increase the potassium in the body. And that's called hyperkalemia. Okay? But cough is one of the troublesome effects of your ACE inhibitors. You can get headache, dizziness, fatigue, nausea, and again, angioedema. Angioedema is a type of allergic reaction. You get swelling of the mouth and the throat, and can prevent these patients from breathing, and patients can die from it. So you have to listen to the patient carefully and make sure this is not occurring. If you give patients ACE inhibitors or HARB, and the lip swells and the patient tell you that they're having problems swallowing, it's best to hospitalize these patients and observe them. Okay? So the important thing with your ACE inhibitor is your cough, hyperkalemia, and your angioedema. All right, so these are some of the common ACE inhibitors in use. The benazepril, captopril, enalapril, fosinapril, lisinopril, perindopril, quinapril, ramipril, and trazodone. So the ones that are more common is we used to use captopril quite extensively a long time ago. We still use enalapril. We use a lot of lisinopril. We still use ramipril and to a lesser extent quinapril. Okay? So these are some of the ACE inhibitors. All right, so we're going to move on now to beta blockers. So there are certain receptors in the body that we call beta receptors or beta adrenergic receptors. Okay, so these beta receptors, when they are stimulated, they do certain things. Okay, so when you stimulate, there are different type of beta receptors. There are actually 3 type of beta receptors. There's one in the kidney. Okay, when you stimulate, there's beta 1 in the heart and the kidneys. When you stimulate the beta 1 receptor, when you stimulate it, you can increase the heart rate and the contractility of the heart. So stimulating beta 1 receptors, you increase the heart rate and the contractility of the heart. Okay, so this may be good in certain situations, that's stimulating the receptors. Beta 2 receptors, mainly in the lungs. Beta 2 receptors mainly in the lungs, also in the gastrointestinal tract, liver, uterus, vascular smooth muscle, and skeletal muscle. And we use the fact that beta 2 receptors are found in the lungs, and when we stimulate these beta 2 receptors, it causes dilatation of the bronchioles. That is, these little tubes in the lungs dilate, and we use that fact to treat patients who have bronchial asthma, because when patients have bronchial asthma, the bronchioles goes into spasm and it clamps down and you can't get air out of the lungs. So if we use beta 2 agonists, if we stimulate the beta 2 receptors in the lungs, then the bronchioles dilate and you can get rid of air in the lungs. Beta 3 is mainly in fat. So when we stimulate these beta 2 receptors, you tend to get dilatation of the blood vessels. So you can when you stimulate the beta 2 receptors, in the lungs you get dilatation of the bronchioles, but in the vasculature, stimulating the beta receptors actually give you constriction, the blood vessel constrict in the vessels, the blood vessels. Again, when you stimulate beta 1 receptors on the heart increase, the rate of the heart rate increase and the contractility of the heart increase. So if we block the beta 1 receptors in the heart, we reduce the heart rate and we can reduce the contractility. And, so that may be beneficial in patients with heart failure. Okay? So if we reduce the beta 1 receptors in the heart, it's going to lower the heart rate and it's going to reduce the contractility of the heart a little bit. If we block beta 2 receptors in the blood vessel, then it's going to cause the blood vessel to dilate and lower the pressure. Okay? So So the mechanism the mechanism of action of these beta adrenergic blocking agents are beta antagonists. So when you antagonize something, you block the effect of that thing. So you can block the beta receptors in the heart and the kidneys, and as a result, reduce the heart rate. If you reduce the heart rate and contractility, you can reduce the blood pressure. If you block the beta receptors and the vascular smooth muscle, it dilates the blood vessel and lower the pressure. So we use these beta blockers to treat angina pectoris, which is uh, pain from the heart because the blood vessel in the heart constricts. Okay, or if you have a blockage of the blood vessel around the heart because you have a plaque inside the heart. If you dilate these blood vessels around the heart, you can reduce the pain from the narrowing of the blood vessels, and we call that angina pectoris. So, given beta blockers, it's going to dilate the blood vessel around the heart, so it reduces chest pain from blockage. Okay, so we use beta blockers to treat angina pectoris. Atrial fibrillation. Remember, one of the things that we said that the beta receptors does when you stimulate the beta receptors, the B1, the beta receptors in the heart, it can increase the heart rate. So by blocking the beta 1 receptor in the heart, we can reduce the heart rate. And you remember, atrial fibrillation, you get a rapid heartbeat. So if we reduce the heart rate in atrial fibrillation, it's a good thing. So you can use beta blockers to reduce the heart rate in atrial fibrillation. Cardiac arrhythmias. So, patient may have some other type of rapid or irregular heartbeat that you can use your beta blockers. Congestive heart failure, because a lot of times these patients will have increased heart rate. And one of the rationale here is that if you have a lot of beta receptors in the heart, it's gonna cause the heart to sort of overwork. So if you reduce some of these beta receptors, the heart will become more efficient. And as a matter of fact, studies have shown that the contractility actually improve. So we routinely use beta blockers in patients with heart failure with reduced ejection fraction because there's something we call upregulate the beta receptors. So you can upregulate the beta receptors by using beta blockers, and as a result get increased contractility. Essential tremors. So patients who have tremors and there's no obvious cause for it. We use beta blockers and it does work, reduce tremors. Glaucoma, and again, hypertension, because when you stimulate these beta receptors in the blood vessels, you can get a vasoconstriction, and if you block them, vasodilatation. Migraine headaches, we use beta blockers for that. Mitral valve prolapse, patients have chest pain, so we usually give them beta blockers. Myocardial infarction, patient having a heart attack, a beta blocker is one of the mainstay in terms of therapy in patients having a heart attack. POTS, this is a relatively new condition, it's been around a little bit. Postural orthostatic tachycardia syndrome. That is, some patients, when they stand up, their heart rate goes through the roof. The heart rate goes very, very high, and as a result of that, the blood pressure falls. So the underlying mechanism here is the heart rate going very, very fast. It's usually a sinus tachycardia, but so it's a sort of inappropriate sinus tachycardia. The heart rate goes too fast. So if you lower the heart rate, then you can normalize the pressure. So postural, because usually when they stand up, they develop this tachycardia, sinus tachycardia, and if you can reduce the tachycardia, then you reduce the problems associated with the tachycardia. Beta blockers commonly used to treat patients with anxiety. If you're going to give a speech and you're a little bit nervous and stuff like that, you can use beta blockers. Hyperthyroidism, because one of the things in hyperthyroidism, you get a rapid heart rate, so you can use it to treat that. Aortic dissection, a rip in the blood vessel wall. There's something we call DPDT, change in pressure with time. Your beta blockers will decrease your DPDT and will be beneficial in patients with patients with aortic dissection. Also, your hypertrophic obstructive cardiomyopathy is beneficial. So beta blockers have a lot of use, a lot of good use. All right, but some of the adverse effects, bad effects. Remember what we said about beta receptors. It causes a dilatation in the bronchial, in the lungs, in the bronchial, the bronchioles, the tubes in the lungs. It causes dilatation. So if you block the beta effects in the lungs, you can get bronchospasm. The bronchioles can constrict. So asthmatic patients can actually get worse on beta blockers. So, the common nausea, vomiting, but bronchospasm. So if you give beta blockers to one of your patients and they start wheezing or having shortness of breath, then you have to be, careful of that. Again, because the beta blockers reduce the heart rate, you can get bradycardia. The heart rate may get too low. You can get hypotension. So this says hypertension, but it's hypotension. Blood pressure can fall too low. You can get heart failure in some patients, because you need some amount of beta receptors stimulation to produce contractility. Heart block, so you can get all different type of heart block. You can get significant first degree AV block, second degree AV block, and even third degree AV block. Commonly, a lot of patients will tell you that they're fatigued. They feel lethargic and tired and a lack of ambition when they're taking beta blockers. So you have to be very aware of that. Okay, you might have to reduce the dose or discontinue the beta blockers if the patient is too fatigued. Alopecia, ear loss. Females will come to you and alert you about this. So you have to be careful. Abnormal vision, hallucination, insomnia, nightmares, erectile dysfunction. So those are the adverse effects. The important one is your bronchospasm. Start a patient on a beta block and they start wheezing or shortness of breath, bradycardia, or heart block. Also alopecia. That's important. Female patients will alert you to that. What are some of the more common beta blockers in use? The non-selective. When we say non-selective, that means they're the selective ones are the ones that are going to act on the beta 1 receptors in the heart. They're going to act on the beta 1 receptors in the heart. Those are selective. The non-selective will act on beta 1 and beta 2. Again, remember that your beta 2 is in the bronchioles, the blood vessels, the gastrointestinal tract. So the non-selective, the common ones is the carvedilol. Okay, carvedilol or Coreg. Some of you guys may know it as Coreg. It has an additional alpha blocking property or activity. Okay, so it's a non-selective, but it also has a alpha blocking activity, and we'll talk a little bit about alpha blocking activity because we use this effect to treat hypertension. Labetalol is also another non-selective, and it has some alpha blocking activity similar to carvedilol. Nadolol we use somewhat. Propranolol, we used to use this a lot. We don't use it so much. Sotalol we use mainly for treating atrial fibrillation. Timolol we use mainly to treat glaucoma. But the common non-selective beta blockers is your carvedilol or Coreg, labetalol, nadolol to some extent, propranolol, sotalol, and so the beta 1 selective agents, that is these agents that act mainly on the beta 1 receptor in the heart. Atenolol is a beta 1 selective agent, and metoprolol, okay? Also esmolol. Esmolol we use as in a drip form to treat rapid heart rhythms such as atrial fibrillation and stuff like that. So the more common beta 1 selective agents is your atenolol, bisoprolol, and your metoprolol, okay? So those are the beta 1 selective agents. Now we're moving on to calcium channel blockers. So as the name suggests, these medications block calcium channels, and by doing so, they cause vasodilatation. They cause the blood vessel to dilate. So you might not know it, but the calcium there's channels in these cells that allow calcium to move in and out. And so when we use a calcium channel blocker, the ones that we use to treat blood pressure, they block the L-type voltage gated calcium channel. And by blocking these calcium channels, they cause the blood vessel to dilate, vasodilatation. And it also some of them reduce the force of contraction of the heart. Not all calcium channel blockers do this. And it decreases the heart rate. So we use these calcium channel blockers to treat hypertension, high blood pressure, because they cause vasodilatation. They dilate the blood vessels. So we use them to treat hypertension. Again, some of them we use to treat angina, okay? And very importantly, because they reduce the heart rate, we use them to treat atrial fibrillation, atrial flutter. So some calcium channel blockers are the mainstay in treating patients with atrial fibrillation with a rapid ventricular response. You cardizem or diltiazem we use for that, and verapamil to a lesser extent. Calcium. So we divide our calcium channel blockers into class, and we have what we call the dihydropyridine and the non-dihydropyridine. The main difference between these two medication is the dihydropyridine they cause vasodilatation, they dilate the blood vessels, so they reduce systemic vascular resistance and reduce arterial pressure. And then the non-dihydropyridine, in addition to doing these things, they reduce the heart rate. So the non-dihydropyridine are the ones that we use to treat our atrial fibrillation, atrial flutter, because in addition to dilating the blood vessel and reducing the blood pressure, they also reduce heart rate, the non-dihydropyridine. And this group includes your diltiazem or your verapamil. So some of the adverse effects, problems associated with calcium channel blockers: dizziness, headache, redness in the face, ankle edema. So one of the big things, if you guys were doing exams and they ask you, some of the side effects, the big side effect for calcium channel blockers, ankle edema. It commonly causes swelling of the ankle, okay? And you can also get headache. So, and then what we say, gingival hyperplasia or gingival overgrowth, mainly with nifedipine, okay? All right. So these are some of the calcium channel blockers. The dihydropyridine, these are the ones that don't decrease heart rate, okay? So amlodipine or Norvasc, okay? Commonly cause leg swelling when you use it. So this is a dihydropyridine, do not reduce heart rate. The common one here is amlodipine or Norvasc. We also use felodipine or Plendil. The others, okay, the other one is your nifedipine or Procardia. The name for that is Adalat. So the three more common ones in your dihydropyridine calcium channel blockers, your amlodipine or Norvasc, your felodipine or Plendil, and your nifedipine or Procardia. So these group of calcium channel blockers don't decrease heart rate. Okay, they're used mainly to treat hypertension. But one of the problem with these medicines, they cause ankle edema, swelling of the legs. So if the ankle edema is significant, you have to stop it. And then nifedipine will cause what we call gingival overgrowth. So if you have a patient and you start a patient on nifedipine, Procardia, and they start complaining that bleeding and the gum is enlarged, and this can be very significant, you have to stop the medicine. Now, the non-dihydropyridine calcium channel blockers, that these are the ones that are going to decrease the heart rate, in addition to causing vasodilatation. We use to treat hypertension. The common one here is verapamil. The trade name for that is Calan or Isopten, and then your diltiazem or cardizem. Okay. So that's your calcium channel blockers. Your digoxin. Now, digoxin is a very old drug. Start using that 1,000,000 years ago. And, the mechanism of action, those of you guys who are doing the exam, they always ask you the mechanism of action of digoxin. It inhibits your sodium-potassium ATPase pump, okay? So it binds to the sodium-potassium ATPase pump in the membranes or house and decrease the function. So you have these pumps, these sodium-potassium pumps throughout the cells, which tend to regulate the amount of sodium and potassium inside of the cells. And digoxin inhibits this pump. Okay, and by doing so, it increased the level of sodium in the myocytes, so inside the muscle cells. It increased the level of sodium inside the muscle cells, and that leads to an increased intracellular calcium. And we think that because you have an increased level of intracellular calcium, then the heart pumps stronger. Okay, so you tend to get a lengthening of your phase 4 and phase 0 of the cardiac action potential. So if you just look back at your action potential, the digoxin is going to increase the length of phase 4 and phase 0. By doing so, it decreases the heart rate. So we usually use it in patients with atrial fibrillation or atrial flutter for this property, because it decreases the heart rate, and it also brings about increased contractility of the heart, because as we said, it blocks the ATPase pump, increase your intracellular sodium, and as a result going to increase the amount of intracellular calcium as well. So that is your digoxin. So we use it to treat patients with heart failure, not so much anymore, but it was a long time ago. It was a mainstay in patients with heart failure with reduced ejection fraction. We still use it in patients with atrial fibrillation, atrial flutter. Okay. What are some of the adverse effects of digoxin? If digoxin is one of those medications that have what we call a narrow therapeutic index. That is the dose to treat the patient effectively, and the dose that can cause toxicity is very close, very narrow. So it has a narrow therapeutic index. So patient can become toxic in digoxin, taking the same dose of digoxin for a long time, and all of a sudden something changed and the level increase and they become toxic. Those patients will present with loss of appetite, nausea, vomiting, and sometimes diarrhea. And as you know, it's not uncommon to see some of the older patients coming to see the cardiologist because they've been losing weight. They're complaining of nausea, vomiting, and they have lost weight over the last few weeks. They have this what they call blurry vision, or they have this yellow green halo that they're seeing. Some of them are confused, and it's just because the digoxin level is too high. So important thing about digoxin in terms of the adverse effect: toxicity, loss of appetite, nausea, vomiting, blurred vision, yellow, green halo, confusion, usually in the older patients. Those of you who do exams, digoxin toxicity, classic rhythm for digoxin toxicity is what we call atrial tachycardia with blocks. So they usually bring this in exam, patient taking digoxin and all different type of medicines, and then they give you an ECG. And once you see that, you should suspect digoxin toxicity, atrial tachycardia with block. You can also get ventricular tachycardia, and with digoxin, we call it, it's more what we call a bidirectional VT. Okay, so these, those of you who do exams, if you see your atrial tachycardia with block, bidirectional VT is usually digoxin toxicity until proven otherwise. So, we used to use digoxin quite extensively a few years ago. We don't use it that much anymore. So what are some of the medical uses for digoxin? Heart failure again, atrial fibrillation, atrial flutter, we said that, adverse effects. And then the next medication that we're going to look at is nitroglycerin. So nitroglycerin has been used for quite some time in medicine. It causes vasodilatation. It dilates the blood vessels, both arterial, both arteries and venous. So it can reduce the pressure. Okay, it decreases systemic vascular resistance and can reduce blood pressure, but it also decreases it causes dilatation of the veins. So you can treat it, you can use it to unload the heart, especially in patients with heart failure, if you're going to give it intravenously. So it also dilates the blood vessel around the heart, the large epicardial coronary arteries. So if patients having, say, heart attack or angina, chest pain because of a blockage or narrowing of the blood vessel around the heart, we usually use it to dilate the blood vessel around the heart. The mechanism of action for nitroglycerin, it brings about it gives you nitric oxide. Okay, nitric oxide, and the nitric oxide activates cyclic. It activates the guanylate cyclase, and that results in increases cyclic GMP in the smooth muscle. So these are basic mechanisms that if you look in any physiology textbook, it's gonna tell you about that. You have these enzymes around the cells. So when we give nitroglycerin, it's gonna form this nitric oxide, and then there's an enzyme we call guanylate cyclase. It activates that, and then your guanylate cyclase is gonna increase cyclic GMP in the smooth muscles. This is just, these mechanisms are there, and then you get dilatation of the smooth muscles. So we use nitroglycerin to treat angina pectoris, chest pain because of narrowed blood vessel around the heart, hypertension, and chronic heart failure. But we can also use it in acute heart failure due to the fact, intravenously, due to the fact that we can unload the heart. So use it for that. So the adverse effects, bad things associated with nitroglycerin: headaches. Commonly get headaches, so look out for that. We can get vertigo. You can get vertigo, weakness, palpitation, nausea, vomiting, syncope. It's not uncommon that you have a patient who is having chest pain and they take some sublingual nitroglycerin, then they pass out. And that's just because it lowered the blood pressure and they have syncopal episode because of that. All right, so the type of nitroglycerin, sublingual, put it under the tongue. Usually patients who are having acute chest pain, we think it's angina pectoris, they'll take one sublingual nitroglycerin every 5 minutes. We usually say not more than 3. Okay, so we use it to treat angina pectoris. We can use a long-acting form, either isosorbide, mononitrate, or dinitrate. Okay, the mononitrate is usually once or twice per day. Dinitrate is usually 3 or 4 times a day. And then intravenously, if the patient is having, say, a heart attack, or the patient is having, patients with congestive heart failure, you want to unload the heart. All right, so we're going to stop here because on Thursday we did antiarrhythmics and stuff like that. But, these medications are very important. So you need to have some basic knowledge about them. Patients are going to come to the echo lab on a lot of these medicines. So you need to know why they're taking the medicines and, have some idea on the side effects or the adverse effects. There's a part 3 pharmacology that we need to do. We need to look at medications that we use for conscious sedation, moderate sedation. So we need to look at those medications because, we will do patients who are having transesophageal echo, and these patients should be, is usually on moderate sedation, and we need to have some understanding of these medications. But we're going to stop here, and hopefully we'll do a session on moderate sedation.